Welcome to my stakeholder education plan. It is nothing short of a miracle that modern methods of instruction have not yet entirely strangled the holy curiosity of inquiry. Albert Einstein was a German-born physicist whose work and influence extends to philosophy and the philosophy of inquiry. In this brief presentation, we will discuss the DNP essentials and their resonance to stakeholder education plan, context for the DNP and relevant implications, stakeholder identification and roles as this pertains to my DNP project, theoretical foundations for an educational intervention, the value of practice change and stakeholder facilitation, and implementation feasibility. In October of 2004, the member schools affiliated with the American Association of Colleges of Nursing voted to endorse the position statement on the practice doctorate in nursing. The DNP is designed for RNs seeking a terminal degree in nursing practice as opposed to a research-focused doctoral program. The essentials of doctoral education and advanced nursing practice are outlined in the presentation, but specifically include methods to improve and transform healthcare, healthcare policy and advocacy, which is undoubtedly examining cost effectiveness and its relationship to social justice and equity in healthcare policy, and interprofessional collaboration for improving patient and population health outcomes. Landmark reports by the Institute of Medicine focused attention on patient safety, the state of healthcare delivery, health professions education, and leadership for nursing practice. Importantly, the Institute of Medicine called for a dramatic restructuring of all healthcare professionals' education. Specifically, healthcare organizations and groups were tasked with efficient and equitable healthcare. Again, this surely commands cost effectiveness analysis and appropriate allocation of resources. Building on the stakeholder construct initially proposed by Freeman in 1984, stakeholders in the healthcare context have been identified as persons or groups that have a vested interest in a clinical decision and the evidence that supports that decision. Stakeholders may be viewed as patients, caregivers, clinicians, payers, decision makers, professional societies, businesses, or policymakers. The organization in question is a health maintenance organization that serves approximately 100,000 lives. And from a pragmatic perspective, the stakeholders relevant to this DNP project are organizational leaders and decision makers, practitioners and clinicians, and payers. The leaders and decision makers in question comprise the senior executive for the organization, a VP for clinical services, a medical director for clinical services, and a program manager for the heart failure program. These individuals are a physician, a pharmacist, a physician, and an RN respectively. All of these individuals have previously acknowledged the significance of the project, while permission for project performance has been requested. As outlined later in this presentation, their specific roles at this time is limited to participation in periodic project reviews. The clinicians related to the project comprise an RN cohort of chronic disease managers and NPs who principally follow this patient population. The frontline staff members will play no role in the performance of this project. Moreover, the routine performance of their job duties is requisite, as deviation from routine practice may influence or skew project outcomes. The HMO itself assumes 100% of the financial risk for the patients served. As such, cost effectiveness and analysis thereof is important, and connecting this project to advancing the interests of the organization is fundamental. The innovation versus value paradigm is exquisitely suited to this project. However, the apparent mismatch of biomedical ethics and the narrow view of business ethics is acknowledged and is referenced here to demonstrate that the topic has been considered while acknowledging that an extensive review of this topic is well beyond the remit of this presentation. The theoretical foundations for the proposed educational intervention are undoubtedly rooted in my professional philosophy and will draw significantly from humanistic psychology, humanistic nursing, and humanistic education. Rogerian concepts including congruence, empathic understanding, compassion, unconditional positive regard, and the central role of the relationship have resonated personally, unquestionably drove my career choice, and a humanistic approach will be employed in this project. The humanistic nursing theory of Patterson and Zerdad and the scholarly work of Kleiman, with their relationship emphasis and human-centered perspective, is intuitively appealing, and parallels with Rogers' aforementioned concept are effortless. Authenticity has been examined extensively in several disciplines, including humanistic psychology, developmental psychology, and dates back to antiquity. And authenticity is key to this process. In 1995, Daniel Goleman described the concept of emotional intelligence, and he talked about its relationship to the working world and the role of leaders. Emotional The educational needs of the target groups comprise evidence. Clinically, the evidence base surrounding the use of telemonitoring, and from a fiscal perspective, the cost effectiveness of the technology will be addressed. Remote monitoring of prognostic indicators of deterioration, for example, weight gain, heart rate, blood pressure, and symptoms, can enable prompt recognition and intervention to stabilize the syndrome and obviate admissions and complications. Telemonitoring per se utilizes the transfer of physiological data to healthcare team members, permitting more frequent assessment of a patient's heart failure status and earlier recognition of hemodynamic deterioration than would be feasible in standard clinical practice, acknowledging the principle that hemodynamic deterioration precedes clinical deterioration. Two systematic reviews and meta-analyses have established and affirmed the clinical effectiveness of telemonitoring in improving quality of life and reducing all-cause mortality and heart failure-related hospitalizations and costs. As alluded to previously, there is no practice change per se, merely a need to educate those involved regarding the theoretical foundations of telemonitoring and its role in the management of heart failure. Clearly a comprehensive step-by-step plan that addresses all of the real and perceived obstacles regarding the implementation of this project is well beyond the remit of this presentation. As outlined in this presentation, no one theoretical construct is sufficient for this process. The role of authentic transformational leadership cannot be underestimated and should be viewed as key to this project. Meaningful global